From Redox and Healthcare Strategy Bullpen, welcome to Diagnosing Healthtech, the show where we talk about healthcare and the technology driving it with the most interesting leaders in the industry.
Good morning, Health Tech. I am Jeff Englander. I'm the founder and principal of Healthcare Strategy Bullpen, and I am joined by my co-host, Elizabeth Ojo, who is a pharmacist and a member of our team here at Redox. Good morning, Elizabeth.
Hey, Jeff. How are you?
How are you down in Atlanta?
A little cold, honestly, but that's okay. At least all the bugs are gone and we're not dealing with scorching temperatures. I'm doing great here. How about yourself?
I'm doing okay. Are you a Braves fan, and are you in a bit of a depression?
So here's the thing. I don't do sports, unfortunately. However, I'm happy to talk about reality TV at any time.
So I can sympathize. I do a lot of sports. My wife does not do sports, and she loves reality TV and true crime mysteries. So
there we go. That's my camp.
Yeah. Well, we're going to have a little bit of a different format today, folks. We are going to do the quick hits, and then Elizabeth and I are going to have an extended discussion on some of the workforce issues. And I think it's a really interesting discussion because I think some of the topics go a little broader than some of the discussion we have had here. So let me get right into the quick hits. So first story is Cigna's Evan North has acquired BrightMD's asynchronous healthcare tech. Evan North's telehealth program, MD Live, will offer their async virtual agent in 2024. Async providers have been using telehealth as a way to move people away from more expensive ED visits and also away from the wait times with primary care. And real interestingly, BrightMD's asynchronous tools don't use AI. They use a kind of decision tree model, and clinicians are involved in every aspect of the decision making. I think this is a good way to expand access. And asynchronous tools, I think, help in many ways for the underserved, who often can't get away for that, travel time and the visit, may be able to text or call, get the question out, and then go back later, for the answer. So I think that's really interesting and really helpful. Also, lawmakers are scrutinizing managed care. Legislators are probing a couple areas for Medicaid and for managed care. In particular, they are looking at prior authorization, both in Medicare Advantage and in Medicaid. They're looking at Medicare Advantage upcoding and in AI. The issues that they are really pressing on is to get real-time authorization in Medicare Advantage, particularly for basic issues. Also, 24-hour authorization for urgent care and greater transparency. I think this, and we'll talk about this again in another one of the quick take stories, but I think Medicare Advantage in particular is going to be a fat target in a year of political disagreement. Most politicians can agree that places that are making a lot of money off of healthcare, are ripe for picking on by politicians of both sides. So I think that's going to be a real interesting issue. Next story, Walgreens chasing profits is going to close 60 Village MD MD clinics, in 2024. Thought this was a really interesting story for a couple reasons. One is, as we talked about a couple weeks ago, Roz Brewer has stepped down as CEO. They have an interim CEO. They just appointed Tim Wentworth to become the new CEO. So I think taking a step like this before he has a chance to create his true strategic picture, I wonder about a little bit. There's a question of how much the biggest shareholder, Mr. Pacina, has influence on the scale, so to speak. A story about that in Business Week. So they're going to close 60 underperforming Village MD clinics and exit 5 markets. There's a soft profit outlook. They're going to cut capital expenditures by $600 million. Also, I think this talks about a tough balancing act that you have when you're in a new entrant, previously in retail, when you have a company like a Village MD, which is growing at about 17%, and you have the back of the store, the pharma business, which is growing about 6.5%, and the front of the store, the regular retail business, is growing about 4%. So I think what this shows is healthcare is a tough business when you're growing in retail, and retail is, really looking at things, really down to the penny. And I think it's just going to show how difficult it is, and how you need to have a little more time to grow these businesses out in the retail environment. On the other side of retail, Walmart is betting their online doctors will lower Walmart's $6 billion healthcare tab. Walmart's going to offer primary care to its 1 million employees on its own plan. Half of the people on the plan don't have access to a primary care doctor. 90,000 of their own employees live in an area where there is no access to primary care. So patients, one of the interesting things is patients who use this service from Included Health were able to lower costs by 10%. And I think one of the things this gets to is, prior to COVID, a lot of companies who were coming into this part of the business, Walmart, Amazon, and a number of others, this was the impetus behind JP Morgan and Amazon and Berkshire Hathaway with Haven, was looking to extend services and use their own clinics as a learning lab. And I think getting back to that a little bit makes a lot of sense. And finally, getting back to managed Medicare Advantage, the share of MA plans that are going to get top star ratings will come down in 2024. The share of MA plans offering prescription drugs and that have prescription drug coverage and that will have coverage and have 4 stars or more will come down to 42% in 2024. That's down from 51% this year and 68% in 2022. And I think the stars ratings, which are an indication of quality and customer experience, are going to be a place of additional pressure for the MA plans. CVS announced earlier this year, because of a difference in MA ratings, it was going to cut their operating earnings $1 billion. Once again, MA, Medicare Advantage, is a place where I think politicians can agree that this is a target, both from both sides, and putting more pressure on MA stars, which are tied to incentives for the MA plans, is an area where I think you'll see additional political theater, if you will, for the MA plans. So with that, let us get to our big picture discussion. So Elizabeth, let's talk about some of the forces that we see, and I think there's some additional ones that haven't been talked about, that are driving some of the workforce pressures in healthcare, and that are really putting pressure both on the providers and their employees. So do you want to go ahead and start?
Yeah, absolutely. I think it's very clear. We see a pattern that healthcare workers are just fed up. There's new headlines from Walgreens, from CVS, that all these organizations, from Kaiser Permanente, that these clinicians are going on strike. They are demanding better working environment for themselves and their patients, better pay. And I think we've really reached a boiling point where frontline clinicians are no longer, it's no longer appropriate to ask them to sacrifice themselves over and over and over again, especially in a post-pandemic world where we're, living in this, endemic period where, it's just not nearly as urgent, I think. And providers are just fed up. They're tired of not being listened to by, executive leadership, by healthcare leadership. They're tired of having to sacrifice patient quality and patient care. And I really am on the side of the providers, obviously, as a provider myself. And I'm eager to see what the other side of this looks like.
Let me play devil's advocate here for a minute, because I agree. And I think, one of the things I think that's going on that and I would usually disagree, but, what bothers me is that, when you're asking the frontline employees to work harder, work longer, maybe take less, I think everybody has to be in on that. Everybody has to be willing to take a cut, you've seen a number of places, and we just talked about Walgreens cutting, the Village MD. If you're
Mhm.
going to do that, you have to be, as senior executives, willing to, kind of share in that pain.
Exactly.
And you see a lot of senior executives, the pay packages, even if they take a cut, the pay packages are still, large multiples of what the
Yep.
field workers are taking. And I don't think you can do that and ask these people to work, long hours under tough conditions, and have that.
Exactly. Exactly. I think 3 years ago, we were in a different world with the pandemic, right? Because while the use, while the patients who were using healthcare were of higher acuity, overall, there was less usage of healthcare, right? But in the last year or so, we've seen that people are going back to their doctors. They are taking advantage of resources that maybe they put off since the pandemic. Surgeries are back on. People are going to their primary care doctors. And guess what? That means that these revenue targets that these healthcare organizations are gaining are increasing, right? As patients are, utilizing more of their resources. So as demand for healthcare has been going up, these executives have been raking in those profits. And yet I rarely see them allocating more resources to those frontline providers who not only have been working for the last 3 years through a pandemic, but have been probably working on skeleton staff, on skeleton crew standards. And it just makes me sick.
Yeah, and I think one of the other things I think that's happened is I think there's been a change in the view or the outlook or philosophy of how we view healthcare workers. I think there was a huge change during the pandemic, in part brought on by the political discourse all around COVID, and whether,
Mhm.
COVID was real, and the ability of masks. I mean, there's been and
Yeah.
we see it now with politics, with the multiple votes, for speaker. There's been a huge undercutting of faith in our institutions, and that's happened in politics, and that's clearly happened in healthcare. And as we were talking in the prep for this, I don't think I've ever seen a time where you would go in and people would, verbally or physically
Yeah.
assault nurses,
Yeah.
doctors, pharmacists. I think that's really part of this that no one's touched on, is the assault on medicine and healthcare and science has really undercut how people view some of these folks.
Yeah, I completely agree. I completely agree. There's this. I think it's that lack of faith that you're talking about. There's this sort of restlessness as citizens, right? They say, okay, maybe I'm powerless a little bit to stop these laws and policies that I feel are violating my personal freedom. So here I am going to abuse this person who's providing me a service, not just in the healthcare space, but we've seen this in all service industries where workers have been putting up with this for since the pandemic, and I think they are no longer taking it, especially in light of the fact that their working conditions have not been materially improved for the kind of work that they're currently doing and having to put up with. Honestly, if you're dealing with the general public at all, you're probably in the same boat.
Yeah. What I wonder about too is the fact that part of what happened um, during COVID, and as we got through these things, is um, there were new ways of delivering care, which
Hmm.
made it easier and more convenient. Suddenly, doctors, hospitals, were forced to embrace telehealth. And when we couldn't get a primary care appointment, all of a sudden we could get an appointment with Teladoc or Amwell or, Doxy.me or whoever. And we were used to getting that not in, 3 weeks, but in, maybe a couple days. And now you have a situation where you your expectations are changed. We've gone through this kind of Amazonization of healthcare, where you want to be able to get it now, get it where you want it, get it in whatever form you want it, whether that's to go into the doctor, whether that's via telehealth, whether that's omnichannel, whatever version. is the ability to do it. And if you can't go into CVS and book that shot and get that COVID shot, before, where you'd wait and maybe say, oh, I understand that's the way things are, you'll just go somewhere across the street and
Exactly.
and you're done.
Yeah, I mean, just like you said, it's the commercialization, right, of healthcare, which, we can definitely talk about the philosophy of making healthcare a commodity rather than than a universal right. But these organizations, they have that profit motive, right? And they are incentivized to not only keep patients within their network, and the way that they want to do that is, you're right, providing multiple modalities of care, telehealth, for one, more accessible minute clinics for another, and trying as best as possible to be able to, provide whatever care that they can be reimbursed for through the patient's insurance. What I found interesting is that one of the solutions that we're seeing a lot of institutions try is delivery of care by non-physicians, right?
Mm-hmm.
So, at least in my pharmacy background, I think for as long as I've been in the industry, there has always been this question, for example, about provider status for pharmacists, right? So that we could prescribe certain medications outside of outside of a protocol that we don't need like an MD to oversee our protocol.
Yeah.
And we see similar fights or similar advocacy for other physicians as well, nurse practitioners, physician's assistants. And by the way, my PCP is a physician's assistant. I love her. I think they're more than able to meet the need of certain conditions that patients may have. I just find it really interesting that that's part of the motivation, right? Is what can we do to expand access, telehealth, more locations, as well as lowering those costs for us on the business side. So by having non-physicians see the patients, and again, all of those are being motivated by this fact of maximizing profit. And again, in my heart, I just don't know if that should be the primary motivator, even if it is leading to positive outcomes, right? Which is increased access and lower costs theoretically for the patient, right? If they're not seeing a PCP.
Well, let me ask you this: if just the two-part question. One is how would you respond to the argument, as a trained pharmacist, that MDs make, that even RNs make, that as a pharmacist you haven't got the training you need, or you haven't had the residency, et cetera, experience you need to either prescribe or treat certain patients.
Mhm.
And then the other part of that is one of the problems we already have is pharmacists at Walgreens and at CVS are saying they're overworked, and if we extend the type of care they're trying to deliver now, won't they be even further overworked?
Let me answer that second question first. You're completely correct, right? In a few years ago, right, laws were passed that allowed pharmacists to give vaccinations, right, at retail sites, right? It used to be you had to go to to see your PCP or to go to a clinic and get your flu shot, for example. But a few
Right.
decades ago, I can't remember exactly when that law passed, they expanded the ability to allow pharmacists to be able to give, your flu shots or your shingles shots or something like that, expanding access. Without a doubt, that has definitely increased the strain of the average pharmacist because um, what ends up happening, the calculus, right, that CVS and Walgreens run is, well, now we have this thing that allows us to generate more revenue, but
Mm-hmm.
we're not going to necessarily staff up, right? We're not necessarily going to give more help to the average store. However, we're going to have these additional metrics of having them, do this additional thing.
Right.
That is definitely a thing that happens. That being said, the kind of person that gets in the healthcare is not the kind of person who is looking to decrease access for patients, right? So on what we try to do and stress, right, maybe through actions like this, like these pharmacy walkouts, like you're seeing at CVS and Walgreens and Kaiser, is by advocating on behalf of better working conditions so that we can execute on this promise of greater access and keeping that high quality care as much as possible. If you browse certain forums, you'll see time and time again, more tenured clinicians, more tenured pharmacists say, hey, I do what I can do, and I make sure that the action that I'm doing, I don't speed through it. I make sure that I'm delivering quality care to every single patient that comes to me. That, of course, comes at the sacrifice maybe of not getting to the number of patients as you would want to, but there's no compromise, I think, for patient safety. Now, the first question you asked me was about the confidence that other providers may have in regards to pharmacists being able to prescribe certain medications. So I actually find it interesting that there would be that doubt, because pharmacists are the medication experts, right?
Right.
And if you've, and it's a very, very common occurrence in a hospital setting, in a retail setting, that prescribers write prescriptions for really, really wild things that they aren't aware of. And it's the pharmacist that catches that for safety and efficacy. And, we go to school for 4 years just to learn the mechanism of actions, for this disease state, this is the medication that is being subscribed. So to be clear, pharmacists are not asking for the permission to diagnose, right? That is not what we go to school for. What we go to school for is the ability to treat diagnoses, right? And be able to look at how medications interact with each other and improve the disease state. So for a lot of really common chronic conditions, I would argue that it's not necessary, right, to have to expect a patient to go to see a provider to renew a prescription if it's something that they've been on for a really long time. One very common option, for example, is oral contraceptives, right?
Mhm.
Or maybe hypertension medications, diagnoses or chronic conditions that the patient is looking to treat that is stable, I think are fair game for pharmacists to be able to prescribe without the purview of being under a clinician, or an MD, excuse me.
Can you give, that was, in terms of the kind of example you gave where clinicians, MDs, RNs, PAs will actually, consult with or, not be overruled, but the input of the pharmacist will be really helpful. Can you give some kind of examples? Are there certain things that they'll teach you in pharmaceutical? Can you talk about those a little bit?
Yeah, absolutely. So the distinction that we have, right, is that, and really I'm thinking about this as the relationship that the pharmacist has with the MD. Obviously, we interact with
Mhm.
nurse practitioners and other clinicians all the time, but just to simplify it, I'll just talk about the relationship with the MD and the pharmacist, right? So the MD acts as sort of the investigator, right? As the person who evaluates the patient, who is able to put together a theory, a prognosis, and a diagnosis. And through that, they're able to reference certain guidelines as to, for this diagnosis, I know that the patient needs this medication. As an example, there are certain disease states that the medication dosing is really, really tricky and dependent on on
Mhm.
multiple factors. One really, really common example is something like an antibiotic called vancomycin that is used for, certain types of infections that can really, really get away from you. However, um, there is a really, really like limited dosing range that vancomycin is appropriate for, depending on the patient's, let's say, comorbidities. How is their kidney function? How is their liver function? What are all these factors that go into the dosing? Frankly, the MD does not have enough time to be an expert on how to dose vancomycin. So what actually happens is that the MD says, I know that this disease state requires this medication. I'm going to leave it to the medications experts to be able
Mhm.
to dose it and monitor it and determine when it's appropriate for the patient to finish it. So it's about that fine tuning of the medication regimen that the pharmacist comes into play, and often actually just manages it completely once that diagnosis and the determination that that medication is appropriate. It's really the pharmacist that does the rest of it up until the end of treatment.
Huh. That's really interesting. I did not know that. I assumed there were certain places like that, but I did know that. So let me ask you this. One of the, problems that I see and that we run into all the time is, there's the problem of demographics in the sense that
Yeah.
you have, we're getting older as a society.
Yeah.
We are also using more medicines as a society. We are
Mhm.
treating more and more things, and especially as we see now with the GLP-1s and the potential
Right.
to help lose weight and treat diabetes. There are more and more expensive drugs coming out. We have that issue. On the other side, we have fewer clinicians. We have a shortage of pharmacists. We're going to have a shortage of nurses and doctors. So, what are would be some of the roles? What would you say? Once again, let me play as devil's advocate. What would you say to someone, at our local pharmacy here?
Mhm.
We had it was closed for 3 days because we couldn't find a pharmacist. So, what would you say to the corporate head who says, "Look, we can't find physical pharmacists. It's not even that they're overworked. We just can't find enough." And would you say that the solution is AI, or what do you say to them when you say, "Hey, it's not even that we're working at them hard. We just can't find enough physical bodies."
So there are many ways to approach that, right?
Oh,
Uh,
yeah, but that's what we're trying to figure
right.
out.
Yeah, absolutely. So the very first thing that I would argue, right, is if we're looking for long-term solutions, I think we have to make the practice of healthcare something that is something that is attractive, right? A job that is attractive for someone to want to do and to want
Mhm.
to go into that field. For a really, really long time, that was pharmacy, right? There was a sort of heyday between the year 2000 and about 2015 for pharmacy where there was that shortage. And we got this huge influx of pharmacists into the space. And actually, at this current time, although there are some markets that definitely there is a shortage, at this time, there's actually a huge supply of pharmacists, but they're not willing to work in these retail environments. So
Okay.
I think and of
Where
course
that?
it is different. I do imagine that we do have like physicians and nursing shortages. But I think that one really, really viable solution for all of these potential shortages is first you have to make the environment somewhere people want to work, right? Is this somewhere where I can find satisfaction in the work that I do, where I'm not micromanaged, where I feel I have autonomy over the work that I do? First, fix that. And then maybe all of the clinicians that have actually left the healthcare field over the last few years because of these issues may return in the first place and then can encourage their colleagues and the people that they mentor or their children to go into the field into the future. I think that's one. Two, I completely agree that we must leverage new technologies to be able to increase the access that patients have. I think going in the direction of using, telehealth and technologies to make the current providers more efficient as much as possible is definitely the way to go. Now, I think AI can be used to power a lot of automated workflows that we have today. For example, just a lot of like administrative tasks that providers are having to deal with on a day-to-day basis. For example, I remember trying to give flu shots when I
Mhm.
worked at CVS, and I loved giving the flu shot. I hated having to prepare to give a flu shot because there were three different forms that I had to print and manually fill out and ask the patient to fill out and all this and all that. And it would have been so
Yeah.
nice to have some kind of tool just to automate that. What is crushing clinicians is not the practice of healthcare, it's the administrative work that
Yeah.
goes into it. So I would love to see some kind of comprehensive, AI tool or some comprehensive technology that as much as possible is maybe automating these administrative tasks until we can maybe have a different discussion about, the discussion about having AI treat and diagnose patients autonomously.
Yeah, no, I would agree, and we actually, and I'll mention at the end, but we actually did our blog piece this week on the pros and cons of using AI to help alleviate some of the workforce issues. And there are a lot of places, and I do think that will be the first place it's adapted, is to help clinicians remove some of this paperwork burden. Even, when we had John Alamka on a couple of weeks ago, John was talking about just having the AI prepare the first draft of a letter to a patient talking about test results or something like that. Because, even that, I think there's a misconception that if certain technologies or certain things only save a couple minutes here or there, but if you look at the fact that most clinicians are spending 90 minutes a day in what's called pajama time,
Yeah.
in bed,
Yeah.
if you start saving them 5 or 10 minutes, or we have one technology we're working with that saves 2 minutes per, ICU client, that, you're giving back a nurse or a clinician or even a doctor lunch, which is a huge deal for some of these folks.
Well, here's the thing, right? A lot of the times, here's what happens, right? Is you give the provider this new tool that saves them 30 minutes.
I'm feeling I know where you're going with this.
You just fill up that time with other
Yeah.
things you expect them to do. It's almost this never-ending cycle of I feel like once there is like an expectation of how much time that you invest into your work, I don't think it ever goes back down. I think the expectation is always it goes up, especially when organizations include these new productivity tools. They don't expect productivity to stay the same. They expect it to actually increase, right? So
Yeah.
I don't know. It's just this paradox, I think, and I don't know that we'll ever see lessening of the work that we expect clinicians, because again, that's just the calculus that organizations run. But certainly, let's try to mitigate as much as we can today, right, and not have it go up as much as possible.
Let me ask you this. When we talked about this a little earlier in the broadcast about the new expectations of healthcare consumers, and how do we meet them, and it's a question of excuse me, getting to people where they want to be served in the method they want to be served. And I think it's important to point out that that is not necessarily the same for that person every time. So someone who wants to do telehealth today because they have a packed schedule and they need to see the clinician quickly is not necessarily the same person who wants to do telehealth every time. They may want to see the clinician at a different time. So I think that's the misnomer. But do you think, given the way healthcare is, the large administrative burden, we're certainly not there. But what would it take to get us? Is it a cultural shift? Is it a tool shift? Is it, what do you think would take to get, to me, we're 2 generations behind to get healthcare to be a more consumer friendly, and I don't want to say retail, but a more consumer friendly like environment.
I definitely think we're getting there, right? Because as organizations grow and, as they're acquired or they merge, I think they expand their network ability, right, to capture patients. So the patient who wants telehealth today, but tomorrow needs to go to urgent care, ideally they're able to capture that same patient within their network. And as we're moving to value-based care, right, it becomes this competition of, this is my patient that I'm treating, so I'd like to be wholly reimbursed for
Mhm.
the lower cost of care that I'm giving to them. So it sharpens the competition that they have with anyone who's not in, the network of providers. So I think we're definitely moving towards that. As you said it best, healthcare is always a generation or two behind current
Yeah.
technologies, especially as an industry. But I can't think of anything off the top of my head that can really speed it up, aside from patients and consumers demanding it, right? Saying, this is how I expect to be, I expect X, Y, and Z when I'm shopping or when I'm traveling, and I'd really like to see it in healthcare. So it's going to be the organizations that get it right. It's going to be the organizations that get it right who, grow their patient base, who are able to have people come back to them time and time again. And the ones that don't, may fall to the wayside just because their competitors are taking all of their business, right? Their healthcare business
Yeah.
essentially. I think younger patients think about it more. I would think obviously, older patients, I think, uh, they just go wherever they like or wherever is convenient, as opposed to maybe a younger population that is more invested in thinking of, well, what's more convenient, rather than, you know, some loyalty that I maybe have to some clinic or some provider.
See, I wonder if that's changing because I think that gets us into really what's driving all this is costs are unsustainable. And you mentioned the younger generation, but even we did a webcast yesterday on value-based care, and I think this is where this is all going. And if you look at Medicare, costs are going from 829 billion to I think 1.4 trillion.
Yeah.
And that's even, I don't want to say forcing, but that's making people, even older folks realize they may have to give up some of the relationship with doctors to go into Medicare Advantage, to go into a value-based care arrangement. But I think really the crux of the value-based care arrangement is, it's integrating care. It's, we're working with people now who are trying to do things to help move to more integrated care. And I think part of that is looking at the EMRs and some of these other systems
Mhm.
were implemented just to check the box on what we have in terms of moving healthcare into the digital age, but they're not really designed to help integrate healthcare to make sure we have
Yeah,
coordinated care. It's much too difficult. You have to check through too many pages to get to where we need to be. So I think we need to think more about how do we help reduce costs by getting more integrated care.
absolutely. You're completely right. EHRs, electronic systems, were created to, for organizations to be able to say that we're on an EHR, and and the creators of those EHRs are not necessarily invested in trying to be the best communicator to other EHRs, right? They want
Mhm.
all other people inside their own ecosystem. And more integrated care, more value-based care is going to be 100% what's necessary to reduce costs. I think in addition to that, I want to encourage, I also don't want to lose sight of the power that policy has as well, right?
Yeah.
It's not as if every country is struggling to reduce the cost of healthcare, right? It is almost uniquely a United States problem, right? Isn't the stat something like we spend 3 times or definitely more on healthcare than any other country in the world, and yet our outcomes are not the best? So I don't necessarily think it's a mystery. I think there are some core ways that our political, economic, and healthcare structure have been put into place that lead to this place where healthcare costs are increasingly rising. And I think one place that we can take a look, to sort of shine some light on why healthcare costs are so high are maybe the insurance companies, right?
Hmm.
This dance that healthcare providers and insurance companies have had to play for all these years, where hospitals are, sending huge bills to see whatever they can get out of the insurance company, and insurance companies taking huge premiums from patients and really incentivized to not necessarily, pay out for the most expensive or, the most appropriate care that a doctor prescribes, but, they're incentivized to look at the care that is most beneficial for their health plan. I think this relationship that the government and insurance companies and hospitals have, this sort of dance that they do, definitely contributes to the high cost of care for sure. And it's not something we see in other countries that have much lower costs while seeing much better outcomes.
Well, I would take issue with a little part of that in the sense that I do think I do think it's more of a problem in the U.S. than in some other places. I don't think it's solely uniquely a U.S.
Sure,
problem
sure.
in
Yeah,
the sense of if you look at what's happening with the NHS, what's happening in some
very
other. industries.
Yeah.
I do think that there's a couple of issues at play. One is, you know, and this gets back to our earlier point about what the expectations are.
Mhm.
In the US, our expectations are to call a doctor and to be able to get to see a doctor for a minor condition within, a week or two. And, in Britain and in Canada and other places, the wait times are significantly higher. And now, unfortunately, they're also significantly higher for other issues, which are more serious. So we've got to, there's, there's uh, a a balancing act, if you will.
Mhm.
What I also do think, I think that the difference here is we, in terms of the cost, I do think there's a tremendous amount spent here on that administrative burden, and I do think part of it is the way the systems are designed, the way
Yeah.
things were put together, and I do think there's ways to make things work better, which is why we're in business, is helping people work with things
Yep.
like value-based care delivery mechanisms, other things that are enabled by digital care to allow follow-up visits to occur virtually that don't require transportation, to reach people who are in underserved communities, either virtually or through other means, so that we can reduce the commute times and the like. So I think that's important.
Yeah, absolutely. I completely agree.
So I wanted to see if there are any questions. I think is there anything else before I actually do that, Elizabeth? Anything else that you wanted to cover that we haven't chatted about?
No, I really enjoyed our conversation. I think we covered just about everything I wanted to get to.
Yeah, well, this is, from my perspective, this has been great. Nothing like, two wonks, talking it up. You know,
Yeah.
So this, thank you everyone for joining us. This has really been a lot of fun for us. Please do check out our blog this week. This week's blog, as I said, is on the pros and cons of deploying AI to confront physician burnout. I do think you'll find it really interesting. Please do come visit us at Healthcare Strategy Bullpen at healthcarebullpen.com. Think of us as the Rosetta Stone between the culture and language of healthcare and technology to help you adapt and deploy healthcare tech to improve the lives of your patients. Please do follow us on LinkedIn and on Twitter at HealthcarePen, and feel free to reach out to us. And with that, I will turn it over to Elizabeth.
Hey everyone, don't forget to subscribe to Diagnosing Healthtech at redoxengine.com/Diagnosing Healthtech to get weekly invites to this very show. You can also email the show with questions, topics, or guest ideas, and anything else that's on your mind. Our show is also sponsored by Redox, the healthcare integration platform that specializes in the implementation of big data, AI, and cloud computing. From all of us here at Diagnosing Healthtech, thank you for watching. See you next week.